Dr. Jenkins, thank you for joining me again.
Pleasure.
How are you doing?
Well, I'm personally fine. I've actually had a few days off, so unlike you, I've not been in the front line just for the last few days, but I'm certainly hearing that here in the hospital things are hopping up very fast.
Yeah, and just to give the people at home a bit of context, so you're one of the respiratory consultants here, and you've actually been on the take, so looking after all the patients coming in. And correct me if I'm wrong, you're actually looking after a kind of ward that's almost dedicated for COVID patients at the moment. How big change for you? How have you been dealing with that yourself?
It's a challenge to the way you work, for sure. You need to think a little bit about your own protection as much as the normal natural instinct to look after others. It's challenging. It takes a lot more time to see patients. I think that they are now dealing with much larger volumes of people of varying ages who are very sick and at times needing to have more emergency treatment like intensive care treatment, but also people at the lower level who are very, very unwell, struggling with their breathing, and of a variety of ages as well. So although this is mainly affecting the older people, we are seeing a number of younger people who are also badly affected. I think we have to be honest and say that the vast majority of the people severely affected in terms of those who may die from this condition are older people, for sure. We still don't know the reasons for that. It doesn't seem to affect children in any severe way, hardly at all. If you look at the data from China and from Italy, the vast majority of mortality, people who died, as opposed to those who were hospitalised, are in people in the older age groups, particularly over 70. I think one of the problems in Italy is that it has a relatively old population. If you look at the breakdown by age in Italy, from what I could see from the data a few days ago, no one under 30 was reported to have died of the condition. That may change, and obviously we've seen in the UK that may not hold true here. So the risks are much lower to people in the sort of 30, 40, 50 age group, but they are still there.
I guess the difficulty with all these statistics at the moment is that we're still learning about it, the way the statistics are reported, they're collected. It may well be the case that lots of people in Italy are, the young are the ones on the ventilators. And
I think that's a fair point.
And so that a lot of people will be on ventilators for many weeks, and then we won't necessarily get all that information. But at the moment, all we can work with is what we know, right?
Yeah. I think that's absolutely right. And I think working out accurate death rates, I think, is very, very difficult. And I think certainly in the UK, I think we need to be prepared for the fact that, there's going to be something of a lag in those death rates due to the fact that some people, sadly, are, going to remain in intensive care for a little while. It sort of brings you on to the idea of how serious or deadly is this condition, and what is what we call fatality rate or mortality rate from the condition. I'm sure everybody's heard various figures of 4%, 7%, 1%, etc., etc. The fact is, none of us know. Now, I don't know whether you think Donald Trump's an idiot or not, but I'm going to throw that in there.
Reserve judgment. In many ways, but go on, I'll reserve rights on this.
I mean, I genuinely feel that too. But interestingly, he made the point, quite early on in this, one of the few sensible points he made actually is that probably there is a wider pool of infected people out there. So it may well be that actually there's more of us infected than we're aware of, and therefore the actual case fatality is probably lower. But, who knows? We simply don't know at the moment. And I think we just have to be aware of the fact that for a minority of people affected by the condition, the consequences are devastating, and that's really all we know.
So it's the combination, isn't it, of having something that may be asymptomatic in people, something that doesn't have a huge death rate, and the fact it's very contagious means that effectively it will end up killing
a lot of people,
purely because it's spreading through the population, and anyone, as we say, who's sort of more vulnerable, elderly, other medical conditions, they have a lower physical reserve anyway, although there may be other things we don't know, like the immune response, that will mean they become susceptible to the complications of it.
And I guess the key thing is that it's obviously a virus that none of us have come across before, so we don't have any background immunity. So we're relying on effectively innate immunity, and that may be why children are better affected. They've got stronger innate immunity. One thing I was going to mention is that obviously you and I as doctors are feeling particularly vulnerable in this situation because we've got higher levels of exposure. Whereas most people are being asked to distance themselves, we're actually being asked to do the opposite, which does seem slightly crazy, doesn't it, to do that?
It does.
I mean, I don't know about you, but it certainly makes you think about your own invincibility and your own mortality in a way that I certainly wouldn't do in my normal practice.
I feel I'm checking myself for symptoms. Like I'm thinking, am I on, if you're a bit tired or you stayed up a bit late, got a bit of a headache, I'm thinking, is this the start of it? Was it that patient I saw? Yeah, it's made me empathise with people that are germaphobes or hypochondriacs.
And I don't know about you, but I've certainly taken a keen interest in the stats on, doctors and nurses who have died from this. And I think it's pretty stark and pretty dramatic. One thing I have observed is that it's particularly the elder age groups that are vulnerable, so doctors who are over 60. So I think my strong view is that despite this call to bring people back from retirement, I think we should actually keep older people away.
Absolutely. Absolutely.
Sadly, I don't quite qualify for that yet. But I also think it's important, as part of this, to reassure young people, whether they're medics or whether they're just in wider society, their actual risk of dying from this is actually incredibly low. Particularly in the under 30s and maybe even in the under 40s. Statistically, the chance of, is very, very low, despite how widespread and prevalent it's going to be. I think the key thing we need to make people understand is that whilst everybody is going to be fearful and anxious, actually the reason that we're doing what we're doing is really to protect two areas. One is to protect the vulnerable, the elderly, and of course people with chronic conditions and compromised immune systems who are going to be much more vulnerable to the virus. But the other absolutely key thing is that is the way that the surge of this infection will overwhelm health services. So it's not necessarily about the total number of deaths that will occur as a result of this, but how quickly the health surges will go on at once and having systems that are overwhelmed. And I guess you and I know that it's very hard to deliver good quality care when services are overwhelmed. And I think that's the key thing for people to get in terms of sort of working out the difference between what is my individual risk and what is the risk to us as a society overall.
It's that common thing going around, the flattening the curve. So it's almost drawing out the number of cases over time to give the healthcare we can for the people that have it, and also so we can almost increase our capacity in the hospital as well. We can and try and meet it as best we can.
Because as you've seen, people haven't stopped having strokes and heart attacks, and people still have cancer. And I think it's important to remember that those are the things that actually are the biggest killers. Still, those are and actually many of the sort of downside from what's happening is that our ability to care for those things is going to be compromised by the epidemic. So in many ways there'll be indirect deaths as a result of this problem as well as direct.
Sure, because with the intensive care capacity and the general medical capacity really directed at this, we need to make sure those services for things where arguably we have better treatments for, we maintain those high standards. That's going to be very challenging. Although I have seen just in A&E, the number of admissions, general admissions, has gone down dramatically.
And I think people are rightly scared of coming to hospital, and I would encourage people not to go to hospital unless you absolutely have to, because it is definitely a place where you're more likely to catch the infection. However, one of the downsides of that, if people delay presenting to hospital with whatever condition it would be, as you can imagine, there would be potential harmful consequences of that. Just wanted to talk a bit about a couple of sort of side effects. So in a sense, the response that we've made to the epidemic is having good and bad effects. So there was data from China about the fact that the reductions in human activity have led to massive reductions in pollution. And it has been argued that actually the reductions in pollution have saved probably thousands more lives than were lost due to the epidemic. So it's just fascinating how these things work and how we're learning a little bit about, in many ways, how ill our society is. Conversely, it's argued, is the sort of treatment, as is society treatment of the disease, worse than the disease itself? Is the economic impact of shutting down work, is that going to cause more problems? We've talked a bit about the adverse impacts on people presenting with health problems, but you've also got, mental health, suicides, the economic impacts and how that will impact on families and so on. So, I think those problems downstream will be massive.
That's really interesting, because I remember Boris Johnson's first interview on ITV. He said about there's an argument to just let the disease run through the population and do it. And loads of people are up in arms about that's not a strategy, that's just letting it happen.
Yeah.
That's a difficult view.
That was a high-risk strategy which had the fingers of Dominic Cummings all over it, I'm sure. But to be fair, I think that epidemiologists differed in their approaches, and I think there was that influenced what's going on back then. So as we speak today, we've just heard that Boris Johnson has been affected by coronavirus. So in addition to Prince Charles, what fascinates me is how it seems to have a predilection for politicians. So there's two possible explanations for that. One is that the virus's genome selectively goes towards politicians, which, as you know, I'm
and
sure
that there's
unlikely.
Something different about politicians' DNA, which we know is true.
But I think more likely what it tells you is that they're representative samples. So
Sure.
in countries like Iran, etc., and here in Europe, politicians being affected, which would kind of imply that perhaps, spread within the population is higher than we're getting through testing. I guess it's fair to say he will have been quite active in recent weeks, and of course the prevalence in London is extraordinarily high. For those of you working in the health service in London now, my heart goes out to you, because it's the stories we're hearing is horrendous, and I think we have to hope that more rural areas that the spikes will be slower and more contained, and that we have to hope that the social distancing measures that everybody is thankfully doing their best to stick to will have some effect. But yeah, I just think I'd like to sort of point out again to people that I think it's natural for us to be scared and anxious, but I think that we need to think about the fact that what we're doing about this is for the good of everyone, but the individual risks to us are still small enough for us to be actually confident about our own personal survival and think about this as doing this for everyone, in fact the greater good.
And also within that as well, I was thinking ahead at when we look back on this time, and I think for many of us, I feel that I'll look back and think, what a strange year, or however long it lasts, and think individually we are likely to lose someone we know, but it's more likely to be someone, an elderly relative or and that's, if people looking back on that will have a totally different idea of what we're going through. That's the worry for me. It's more like the family, the older members.
Yeah, we have to be aware of as you said before, the limits of what you can do for treating people who are severely affected by the condition. And so one of the things I guess we need to think about a little bit is how we can somehow provide comfort and dignity in death for people who are dying from this condition. I think that's a tough one.
Yeah, that's something I wanted to pick up on actually, because from my view in the emergency department, it's very unlikely for a patient to come within the 4-hour window in A&E and then have, deteriorate. Talking to the medics this week, so the team that you look after, it really, set me back about what they're seeing on the ward. Often elderly patients who are coming to the ward in masks. Everyone's in masks. It looks like this very strange environment. They're maybe they're not allowed visitors. So they normally, as we know, people rely on that kind of 2-hour visiting window to get a sense of reality, because they're in a strange environment in the hospital, very dependent on everyone around them. They're not necessarily that tech savvy, so they don't, and very, for a small but significant percentage, that may be their last days of life. And that is...
It is tragic to think that. And I think, when this was brewing over the last few weeks, that was one of my biggest worries actually about that. So we did spend a lot of time talking to chaplaincy service, palliative care service about how they could work this through. And I think this is probably an area that everyone's going to have to be thinking about now. The big problem, of course, is there isn't any way around the problem of, social distancing, in the sense that, realistically families can't be with loved ones for all sorts of reasons. As you know, and we talked a little bit about this last time, when people come into hospital with suspected coronavirus infection, you have to try to make a decision about, how ill someone is and how badly they're affected by it. Bearing in mind, not every old person is going to succumb to this.
Sure.
As with everyone else, in the older people, it can still be a mild illness. It's not going to, affect everybody badly. But for those who are obviously affected badly in looking at their breathing, then the question is, how bad is their underlying condition? What would their chance of surviving if you were going to go through an intensive care situation, which is, being on a ventilator, putting into an induced coma, something that's very tough for a young, fit person to survive. So, as you know, we have to sort of make a decision that, somebody who has advanced age with lots of other medical problems, it's not in their best interest to do that.
No. And I think a lot of people at home might not necessarily realise that a ventilator isn't just a magic machine.
No.
It's extreme trauma on the lungs, having that air forced in. You're put in an induced coma, which is not a natural thing to do. And by having something breathe for you, all your normal muscles of breathing, all the tone goes out of them.
Yeah.
And trying to get someone off that is often impossible, isn't it? So we have to really pick the people that...
I think that's right, and it may seem harsh, but actually that is the reality. And I think that there's been a lot of motive discussions about the idea of do not resuscitate orders and the rest of it over recent years. And I think it may well be that this infection brings that into focus a little bit more, and we all should be encouraged to talk to our parents, our older relatives, and have this discussion out in the open early. And I think that once you've made a decision has been made that somebody with severe coronavirus infection is not going to be put forward for intensive treatment or possible intensive treatment, you're then in effect in a situation where you're still hoping somebody might have a chance of getting better, probably a small chance at that point, but you have to try and prepare for death, try to offer dignity, try to relieve distress, manage symptoms. And I think that is going to be something that's going to be a real challenge to do without that human face-to-face contact, easy access to families, and for the palliative care nurses it's going to be a very, very challenging time, I think. But I think innovative ways will have to be found to do that.
Just to pick up on your point as well, that many older people will come in and the supportive care we give on the wards will be enough and they will be discharged home. But also within those people, we should say that they will have discussions around what will happen if things go, if they end up coming to a sort of end of life. And people shouldn't be surprised if they come into hospital and we bring that up early, because the time to bring it up is where people are kind of well. In terms of when they come in. And it's important to have those discussions then, rather than wait a few days, things are not really going where we expect. And then you're presenting to someone after hearing bad news and it doesn't work. I think people as well think that CPR works in the movies, where we jump up and down on someone's chest, we give them an electric shock, and then...
And you've debunked this thoroughly before in your videos, Ed. I mean, I think it's fair to say.
That was a plug.
So if you want to find a bit more about that, I think Dr. Hope's sick notes can provide that information for you. But it is, you're absolutely right.
It doesn't stop the underlying process that's got us there.
No. And I think what I've noticed before this coronavirus is that we're trying our best to increasingly have these discussions with everybody early on during a hospital admission or in GP surgeries. And often it's sort of said, well, why did you have that discussion? What was that for? You didn't need to have that discussion at that point, but actually you do. And I suppose part of the reason for this discussion we're having today is for us to just talk a little bit about death and mortality, an honest discussion about it. It's a difficult topic, certainly a difficult topic for me. I'm sure it's for you as well.
Absolutely.
But I think this pandemic has made us all think about our mortality, and probably the more honest way we can do that, the better.
Dr. Jenkins, thank you so much for joining us.
Thank you, Ed. Yeah, thanks for giving me a chance to talk about it. It sort of helped me get some things off my chest, I think.
Right, cool. And we hopefully catch up again.
Yeah, definitely.
I'll keep trying to grab you for your awesome insight.
I'll look forward to it. Yeah.
Thank you.
Thank you, Ed.